Medical orders for scope of treatment came into effect across Interior Health in June of 2015. This replaced previous no CPR, DNR, and leveled intervention orders. Regardless of what we call the orders, having conversations with our patients and their families about their wishes and the various treatment options that are available can be challenging. Hello, I'm Dr. Scot Mountain. I'm an intensivist at the Kootenay Boundary Regional Hospital in Trail, and I have these conversations with my patients on a regular basis. I'm often asked about the best way to structure a discussion about treatment options. I think of the process as similar to that for obtaining informed consent. First, we need to get an accurate understanding of the patient's wishes. Then, we need to supply the patient with clear, understandable information about the interventions being discussed. Once these things have been accomplished, we can have a meaningful conversation that allows us to reach consensus and agree how to move forward. So how do we do all that? In this session, we'll discuss ways to make these conversations informative and effective. We'll also take a quick look at approaches we can use if consensus can't be reached. My own practice has evolved into a simple three-step process. At first glance, it could look like this might take a lot of time, but in reality it can be done fairly quickly in the clinic or at the hospital bedside. So regardless of whether you're having these conversations in the community, residential care, or acute care settings, the same approach can be used to arrive at a plan of care. First, it's important to improve our knowledge about the patient's background and the intellectual and cultural framework on which their wishes may be based. In this step, you can also incorporate feedback from other members of the family or the interprofessional healthcare team, especially when the patient may have difficulty communicating their ideas on their own. The second step is for you to improve the patient's understanding of the interventions being offered by explaining them in a clear and understandable way. It's important to know that healthcare providers often jump into this step right away, and they skip the first step. While this may seem more efficient, it often makes things less clear and leads to unwanted or unnecessary interventions. Once both parties have an understanding, then we make an attempt to determine what the most appropriate most status is for the patient. I'll go through each step in slightly more detail. As I mentioned, once you get used to the idea of addressing each of these three steps in your conversation, the whole process can be streamlined and efficient, while still being effective in arriving at an acceptable plan of care. Again, step number one is where we strive to understand the patient's framework and perspective. The most important part of this step is to sit and listen to the patient. Busy healthcare providers often have a hard time slowing down and listening. But in my experience, it's very powerful to sit down and let the patient or family talk. It's amazing what comes up and what you can learn. In addition, forcing yourself to take a little extra time in this step often saves significant effort in confusion or unclear treatment plans down the line. Ideally, this step is done in a quiet, uninterrupted environment. We should consider who needs to be involved in the discussion. If the patient is competent, the conversation would require the patient's permission to include others. Often, they may want a loved one with them, as the support is helpful. Sometimes, other healthcare providers who know the person well can provide some background information. The best way to approach this conversation is with open-ended questions, aimed at gaining an understanding about where the patient is coming from and what things were like at home. When asking the patient or family to explain in their own words what's happening, you're attempting to gain an idea of what they know about their illness and their prognosis. It's remarkably common for patients to have an inaccurate understanding of their underlying illness and their prognosis. The other thing that's amazing is that when you get people talking about how they spend their time or what they do for fun, it often becomes very apparent to everyone in the room what direction things should be going. If you give the patient or family time to reflect on their recent living situation and health issues, the appropriate most status usually becomes apparent to everyone. So, open-ended questions and active, intentional listening are very valuable. Once you've achieved a good understanding of the patient's background situation and their medical, social, and cultural framework for decision-making, it's time to step in and provide some information. It's really important to remember to do this as a second step and not the first step. There are several critical pieces of information that you need to give to the patient. Firstly, what are the medical problems as you've assessed them? What are the underlying issues? What is a prognosis? This can often be very vague for patients. It's important to be as clear and as factual as possible regarding prognosis. You also need to let the patient or family know how you have arrived at your conclusions. What diagnostics have been done, and if experts have been involved, what are their assessments? Frequently, there will be some uncertainty in parts of this information. It's important to let your patients know what you don't know. You need to embrace and admit to areas of doubt or where the diagnosis or prognosis are unclear. Being open and honest about the areas where information is lacking helps to build trust with your patient, and it also provides the necessary background for patients to make critical decisions regarding the direction of their healthcare. So make sure you include a discussion about uncertainty when it exists. Once all the necessary background information has been exchanged, it's time to determine what treatment options exist and why they may be beneficial or not beneficial. It's important to do this carefully, using layman's terms and being specific. In the intensive care unit setting, for example, I use terms like breathing machine, tube in the airway, shock to restart the heart, or pushing on the chest to keep blood flowing. I don't do this to be overly graphic about intensive care informations. Instead, I do this as an attempt to help the patients really understand what we're talking about. It's also important to make sure patients are aware of all their healthcare alternatives. We need to discuss all the options, including comfort care, with a specific description of what each alternative looks like. Discussion of the option of comfort care is often left out, and many patients have no idea of what comfort care is. However, if you describe comfort care to patients, it's often clear that it's the most appropriate and palatable option. When discussing comfort measures, I avoid using the term palliative care, which is often confusing for patients. Instead, I use the term comfort care and emphasize that it's not a withdrawal of care, but ongoing care with a goal of comfort instead of a goal of cure. I'm clear that the end result of this approach is usually death, often using phrases such as natural death, death with dignity, or death without pain. It's critical we don't use the phrase, "Do you want everything done?" This is extremely vague for patients and sets up a false dichotomy between doing everything and doing nothing. The truth is, we're not deciding between doing everything and doing nothing. We never do nothing. This terminology can be very frightening for patients and can lead them to feeling abandoned by the healthcare system. Instead, we need to be clear that we're deciding between different approaches, including possible comfort care measures. When making decisions about the various options, it's critical that patients understand the chances that full resuscitative efforts, which is a MOST designation of C2. So, as a healthcare provider, you need to have some understanding of what the outcomes of CPR are in various situations. Often it simplifies things for patients to describe what is normally done, or what the physician proposes to do and why. Another strategy that patients often use to make things accessible for them is to ask the healthcare provider what they would do in the same situation. Personally, I think that's a fair question because it really does humanize things. There's a large body of literature looking at in-hospital resuscitation outcomes. It's important to understand a rough summary of the literature so you can give people a reasonable idea of potential outcomes. The chances of surviving an initial in-hospital arrest is about 50%. But when you look at the chances of surviving a hospital discharge after an in-hospital arrest, it's much lower, somewhere around 15%. There's some variability in the numbers depending on the patient's age and underlying comorbidities, with the extremely elderly and those with pre-existing cardiac pathology doing worse. Patients who undergo an unwitnessed arrest are less likely to survive than those that have a witnessed arrest. When all the information has been traded and the patient or family has all the relevant information about appropriate options for care, it's time to try and reach a consensus on healthcare preferences. It's important that this be seen as a collaborative decision. It's not the patients or families alone. It's appropriate for the healthcare provider to be part of the discussion and to voice their opinion in a non-judgmental manner. This can help to share the often overwhelming burden of a monumental decision for patients during a difficult time. If family members are having difficulty coming to a decision on behalf of a patient, it's often very helpful to refocus them on the patient's wishes. I often emphasize that we're trying to determine what the patient would want if he or she could participate in the discussion, and that we often need to avoid letting our own wishes complicate matters. This leads to one last important point. It's critical as a healthcare provider to avoid an agenda. Patients and families often need time to come to a consensus, even in cases where you think the decision might be obvious. Once the patient or their family has all the relevant information and knowledge, if they're still having trouble reaching a decision, instead of pressing forward too hard with your own opinion, it's often better to back off, postpone completing the MOST, and give them time to think without any pressure from the healthcare team. Here are a few more sample phrases that I've found useful in this stage of the MOST discussion. Something I ask of everyone over a certain age when they come into the hospital is, have you ever thought what you would want done if your health deteriorated suddenly? If your father was here meeting with us, what would he say? What kind of care would he want in his current situation? What I really need you to think about is what your mother would want, not what you would want or I would want. Let's really try hard to focus on her wishes. I don't want you to feel like you're making medical decisions. That's my job. But you know your father better than I ever could. Do you have any insight as to what he would have wanted? Your father provided instructions in his advance directive regarding his preferences on how to proceed in this type of situation. We need to respect his decision and follow those instructions. Some of the difficulty in having most discussions is that healthcare providers are often worried about what to do if the patient or family wants a level of intervention that seems inappropriate. In this situation, the first thing to remember is that it's okay. It's not necessary to reach an instant agreement. Instead, do a mental check-in with yourself and see if you've been caught in the trap of pushing an agenda. Remember to try and avoid this, as it can make things extra difficult for everyone. Remind yourself that this is an incredibly difficult time for the patient or their family, and this is a decision that has varied implications and is probably above and beyond the level that they're used to. Most people have never discussed life and death issues before, and it can be very hard the first time. Recheck that all the relevant information has been provided, and that the patient or their family understands everything, and that their questions have been answered. If you've broached the discussion the way we've talked about, you've definitely given people some things to think about. Focus again on the patient's perspective if you're still having trouble reaching agreement. Again, be sure you're not being too confrontational. Step back and leave some time for discussion, re-emphasizing the important factors. Be sure you've acknowledged any uncertainty in the medical information and that you don't know for sure what the outcome will be. This lends your role in facilitating the decision credibility. You can say, "I'd be happy if I was wrong, but this is what I think. Based on my knowledge and previous experience, this is the most likely outcome." As healthcare providers, it's important to take our ego out of the equation. If we can't reach an agreement, it can be helpful to have a second opinion. If the second opinion doesn't agree with ours, that's okay too. I like to make sure that patients are aware of all their options if they don't agree with the proposed direction of care. Sometimes this includes making them aware of any legal options if that's relevant. I hope these ideas will prove helpful in your future discussions with patients and their families. Once again, the key messages are: decisions are best made with patients and families, physicians who know them, and the interprofessional healthcare team. Remember that the first step in the process is to understand where the patient is coming from. Use open-ended questions to understand the patient's background and what things were like at home. Beginning the discussion by listening will help to gain consensus. The second step is to provide information. Make sure the patient and family understand what the problems are, what the prognosis is, and how you've arrived at your conclusion. Remember that most patients don't understand resuscitation without significant explanation. Determining the most designation should be a collaborative decision. It's not the patients or families alone. Voice your opinion and be part of the discussion, but avoid having an agenda. Give the patient and family time to make a decision. And finally, when things get difficult, it's okay to ask for help. This might be talking with a colleague, consulting an ethics committee, or asking for a second opinion. If you need more information, here are some additional resources.